Hi, I'm Marcus Scher, Director of Cardiac CT at Sanger Heart and Vascular Institute in Charlotte, North Carolina, within the Atrium Healthcare System. Today I'm going to be talking to you about coronary CT angiography and how we optimize images for clinical practice. There are many important factors that can affect image quality when you do a coronary CT angiogram. These include patient preparation and selection, CT staff expertise, equipment and protocols, and image reconstruction. Let's first touch on patient selection and preparation. Coronary CT angiography is an excellent modality for evaluating our patients with chest pain. We can determine the extent of coronary disease a patient has and characterize plaques and stenosis, and now we can also assess for ischemia with FFRCT. In order to do this well, though, we need to have good quality images. And patient factors can influence image quality and acquisition. When we select patients, we can have two types of patients. We can have a simple cardiac scan, or we can have a complex scan. For the simple patient, the patient will typically have a body mass index less than 30, a slow and regular heart rate, and the ability to hold their breath or hold still for 10 seconds or more. It's also imperative to have good IV access, and it's helpful if they have normal renal function so you don't have to limit the amount of contrast necessary. Also, it's easier to scan someone who has no established history of coronary disease with stents or coronary calcium. Then we have difficult cardiac CT scans. These patients can be much more challenging. They may have a high BMI, so the images may be noisier. The heart rate could be an issue if their heart rate's high or they have arrhythmias, making gating challenging. And they may be unable to hold their breath or hold still, resulting in a variety of artifacts. We can also have issues with suboptimal IV access so that we don't have adequate contrast, or if the patient has chronic kidney disease, we can run into issues with limitations on contrast. We also have complex scans related to inherent patient factors. For example, if they have severe coronary calcifications or stents or pacemakers, this can cause blooming and problems with assessing the lumen. So starting off with patient preparation prior to their coronary CT appointment, we have to give them some pre-exam instructions. And some of that is hydration. Oftentimes patients are told to not eat or drink anything before a CT scan, and sometimes that's a mistake because when they come in, they can be dehydrated, and it can make it challenging to put an IV in if they're coming in dehydrated, and can also limit their blood pressure and your ability to use medications such as a beta blocker or nitroglycerin. It's also important that we avoid stimulants such as caffeine-containing products, and that the men don't take medications for erectile dysfunction because that would preclude our ability to use nitroglycerin. We also can pre-medicate the patients with rate-lowering medications, sometimes the day before or morning of, or in a holding area with oral beta blocker. And these sometimes can be provided by a prescription or by samples from your office. What about CT staff and expertise? The CT staff, including technologists and nurses, can have a dramatic impact on the outcome of image quality on your scans. They provide patient instructions and expectations, breath holding, coaching, IV access, and attach the ECG, which is imperative for appropriate gating. Signal and ECG electrode placement are very important. We have to place the electrodes in a good position to capture a good ECG signal. We need to maintain good contact on the skin. It's also important that the patient is comfortable in a position such that there's not trembling or noise and they're not gripping onto anything. ECG directs the timing of radiation delivery and reconstruction, so it's very important that the ECG counting mechanism is correct. We will show examples of how ECG noise and counting errors can occur and ruin scans. Recognition of the differences between counting errors and true arrhythmias is very important so that we can address these before the scan and sometimes during reconstructions after the scan. Let's now talk about ECG rhythm strips and commonly encountered rhythms during cardiac CTs. First, we have sinus bradycardia. This is the ideal patient with a nice regular rhythm. This is optimal for coronary CT. Oftentimes, we have normal sinus rhythm, not sinus bradycardia, as shown in this strip here. And this is a patient that we commonly would give a beta blocker to slow the heart rate and get better images. However, we also commonly encounter arrhythmias in the lab. And here's an example with the arrows here demonstrating premature atrial contractions that cause an irregular rate. This is very important to recognize because we may have to acquire the images differently or reconstruct the images differently. Next, you can see a patient with atrial fibrillation. Sometimes the baseline can look like noise, but it can actually be an arrhythmia, as in this case, which is atrial fibrillation. Again, it's important to recognize this rhythm because it can affect your scan technique and your reconstruction method. Lastly, and one of the most difficult scenarios in cardiac CT, is the scenario of premature ventricular contractions. This can cause an irregular rhythm, a different QRS morphology, and make timing very difficult. So here is a slide demonstrating ECG noise and counting errors. This is on the top, not actually an arrhythmia, but you can see in the red circles where there are incorrect syncs placed on P waves rather than on the QRSs. This causes problems because the radiation may be delivered at the wrong time, or when you reconstruct, you may have reconstruction errors because of timing issues. Below is also a patient with ECG noise and counting errors, but if you scan with a different technique, you can sometimes edit out the counting errors and remove those, which we will show later. For IV placement and contrast, we prefer to use an 18 gauge IV. We also like to avoid smaller IVs such as 22 gauge. This can make injecting contrast at a high flow rate, which is very important for coronary CTA, difficult. Typically, depending on patient size, we will inject at 4 to 8 milliliters per second. We like to avoid IV kinking, and we like to use warm contrast. Those are very important features because if we use warm contrast, we can inject at higher flow rates without hitting pressure limits on the injection. Moving on to equipment and protocols. What you can do with your patients can largely be dependent on the type of CT scanner you have. There are different CT scanning technologies and equipment that affect your ability to scan patients. There are scanners that have wide detector coverage that manage to scan the patient in a single heartbeat. There are scanners that have higher temporal resolution, which allow you to capture images of patients with higher heart rate with less blur or motion artifacts. All the scanners have generally good spatial resolution, but some have better than others. And all the scanners have the ability to fluctuate the amount of tube output, and some scanners can have more tube output than others and have greater ability to scan obese patients. You also need a standard power injector with a dual head so that you can inject contrast and have a nice saline flush behind it. It's also important that you monitor the pressure during an injection to make sure the patient's IV can tolerate this. And this can occur during your test bolus imaging so that sometimes you can know if you will be able to use the high flow rate that you want to on the main scan. Contrast warmer, as I mentioned, is very important. We typically maintain the contrast in a warmer at 37 degrees Celsius, roughly around that range, and it helps lower the viscosity, enabling higher injection rates without hitting the pressure limit on the power injector. Moving on to scan protocol setup, we will talk about the topogram, a test breath hold method of imaging, and acquisition mode and timing for ECG considerations, and the tube settings. Starting off with the topogram, it's important that you make sure the heart is well isocentered. This can affect not only your spatial and temporal resolution to be optimal, but it can also affect the radiation delivered to the patient if your scanner uses automatic exposure algorithms to determine how much radiation the patient needs based on size. Test breath hold imaging is something we use at our facilities to minimize motion artifacts during the scan. This offers an opportunity for you to actually image and see whether the patient is capable of holding their breath with a very little radiation exposure. There's pattern recognitions you can see when you do this. There's some patients that are incapable of holding their breath on inhalation or exhalation, you can use this information to help determine which breath hold technique is best. Here's an example of test breath hold imaging. This is a patient that was completely incapable of holding their breath. The question is, can we scan this patient? On the left image, before the patient received contrast, you can see that there's sternal movement when they were asked to hold their breath. Despite multiple extra efforts at coaching for appropriate breath holds, on the right you can see during the test bolus the patient continued to breathe with repetitive sternal motion. Fortunately, because we sometimes have methods of scanning the patient in a single beat rapidly, even if they are breathing, we can generate good scans. In this case, we used a high-pitch helical acquisition that scanned the patient in a fraction of a heart cycle within less than 250 milliseconds, and we got motion-free images without misalignment artifacts. This was very contingent, though, on the patient having a suitable heart rate in a low and steady range. You may also be able to achieve similar successful results on a wide detector array volumetric scanner. Here's an example of a patient that is breathing during the test bolus. It's important to identify this because if they're breathing during the test bolus and not holding still and holding their breath, we can have misalignment artifacts during the main scan. This is an example of that same patient who was breathing during the scan, and you can see a marked misalignment artifact right over a plaque. And you can imagine how difficult it is to assess a stenosis in this situation. This is the same patient re-imaged and re-coached to hold their breath appropriately. You can see now this time when this was caught that they didn't understand how to hold their breath, and we coached them again, and now they have no sternal motion, and this is a good breath hold. Now you can see the image on the repeat scan showing no misalignment artifact and clear depiction of the plaque and stenosis. And if you compare that to the other scan where there's motion artifact and misalignment, you can see the difference clearly. Here's another example of using test breath hold images before contrast, which can be very helpful. This patient with multiple inspiratory breath holds was unable to hold their breath and was repeatedly exhaling air. It was very important to recognize that pattern. On this follow-up slide, you can see instead when we told the patient to exhale, they no longer expired air and they held still and there's no sternal motion. As a consequence, we got excellent diagnostic images on this patient with no misalignment artifacts, and you can see the image quality is good even though the patient had atrial fibrillation on this scan. Because this patient held their breath well, we got excellent images on this 3-beat axial sequential acquisition. Moving on to acquisition timing and the ECG waveform, I think this is very important so you understand some of the fundamentals of why you acquire when you do. If you look at the ECG, you'll see 3 red zones on this slide, labeled atrial contraction, ventricular contraction, and rapid filling or rapid diastolic filling. The zones in red represent times in the heart cycle when there's a lot of cardiac movement, and they're suboptimal times for imaging the coronary arteries. On the other hand, the zones in green representing isovolemic relaxation on the end of the T wave, and on the right you see D representing diastasis. Importantly, those intervals have much less cardiac motion. In addition, you can see the width of the rectangles in the time dimension, left to right. The wider the green box is, the more time you have to capture an image motion-free. If you have a lower temporal resolution scanner, you can see why you need to have a lower heart rate and use beta blocker based on the width of the rectangle on the right can vary with heart rate. The lower the heart rate is, the wider the green rectangle representing diastasis becomes, and the more opportunity you have to capture a motion-free image of the coronary arteries. So when you give a beta blocker and you expand your TP interval and that diastasis time, you'll be able to capture a motion-free image at a lower heart rate. On the other hand, with isovolemic relaxation on the end of the T wave, that tends to stay fixed, fairly independent of heart rate. And if you have a high temporal resolution scanner, you will be able to capture images on the end of T waves on high heart rate patients or patients with irregular rhythms. Here's an example of systolic or diastolic coronary imaging. What we tend to find is systolic imaging at end systole tends to be on the downstroke of the T wave, whereas the best diastolic image tends to be just before the P wave. And that makes sense based on what we said with when we predict cardiac motion occurs. In general, once we hit heart rates that are more than 75 beats per minute, we rely on a higher temporal resolution technique and imaging and reconstructing on the end of the T wave. However, low heart rate imaging is always the highest quality imaging if it can be achieved because it has the least amount of motion. So if we can image a patient pre-P wave on a low heart rate, those will generally be the highest quality scans. Generally speaking, we will find that heart rates less than 65 or 60 are more ideal for pre-P wave or diastolic imaging. There are 3 different scan modes encountered in practice. There's axial scan mode where the table doesn't move. That can be with a single beat wide detector scanner, or it can be over multiple heartbeats when you don't have full cardiac volume coverage with a single rotation. There is also helical low-pitch spiral acquisition where the table moves slowly and acquires the heart over multiple heartbeats. And lastly, there's a high-pitch helical mode where the patient's heart is imaged over one fraction of one cycle by moving the table very quickly. And during this time, you're counting on imaging the patient during diastole in order to capture the full cardiac volume while the table is rapidly moving through the Z-axis coverage. Tube settings are very important. Body mass index or body habitus size, shape of the patient has a great impact on image noise. And we offset image noise by increasing tube current settings or increasing KV. But there's more to it than that. We have to consider sometimes that patients have complex scans because of coronary calcifications or stents. And in these situations, we need to consider provisionally upping the tube settings regardless of the patient's body habitus, because dense calcification can affect your image quality. And calcification plus motion can be particularly problematic, and it may influence your decision to sample more phases. We also need to apply radiation responsibly so that the patients get the correct dose for their needs. So for example, if we have a young patient that has no coronary calcium and a low disease likelihood and more risk from radiation exposure, we want to be very diligent about doing what we can to maintain minimal exposure. On the other hand, if we have a patient that has lots of coronary calcium or stents, we may want to increase exposure in order to get diagnostic images. The last thing we want to do is have a non-diagnostic scan. Here's an example of why we may need to adjust our tube settings based on calcium burden. You can see that when we have this much calcium, we want to use a sharper kernel reconstruction. That improves the resolution, but the trade-off is more noise. How can we offset noise? We can do that by increasing tube current and raising KV if necessary. And you can imagine how the more resolution we need, the more noise we have, how if you know this ahead of time, you can prospectively adjust your tube settings to accommodate. You can also see what the improvement is in these reconstruction kernels to limit blooming. You can see this on the left is a smoother kernel reconstruction, and on the right is a sharper kernel. The calcium is less bloomed, and you get a better sense of what the lumen is with contrast versus calcium. How can we identify the calcium burden to decide on tube setting adjustments? We can do this by a calcium score, which many centers do. You can also do this with a very low exposure non-contrast chest CT technique and qualitatively get an idea of how much calcium the patient has to adjust your tube parameters accordingly. There are a number of medications commonly used provisionally at the scanner depending on patient factors. First and foremost, achieving heart rate control is critical, as we've discussed. This can be done with IV beta blocker, including metoprolol, that can be given in addition to the oral metoprolol or if the patient didn't take oral beta blockade. We also have situations where we need to use miscellaneous medications, and we'll go over that briefly. Nitroglycerin is key to achieving maximum coronary vasodilation and improving our scan interpretations of both stenosis and also FFRCT analysis. By SCCT guidelines, we administer nitrates like we do with any coronary CT, and we prefer to use 0.8 milligrams of sublingual nitroglycerin if possible and the patient's blood pressure permits it. We also prefer to give the nitroglycerin within a window that's 3 to 5 minutes prior to the main scan being acquired. And it's very important to make sure that if you use sublingual tablets over spray, that the tablets have dissolved before you proceed with the scan. Sometimes patients have a very dry mouth and the nitroglycerin does not dissolve. If that situation presents itself, we need to come up with measures to help them get moisture under the tongue. That can be as simple as taking a straw with a droplet of water applied under the tongue to help the nitroglycerin dissolve. Here's an image of a heart with a patient with an elevated rate, and you can see excessive coronary motion, which can be particularly problematic in the right coronary artery. Had this patient been more appropriately beta blocked with a heart rate less than 60 beats per minute, a different result and better image may have been observed. Here's a complicated situation of premature ventricular contractions. In this situation, the patient is actually having very frequent PVCs, and you can imagine how detrimental that can be to both image acquisition and reconstruction. This patient was given medication for suppression of premature ventricular contractions, and the rate became regular and consistent. And even though the heart rate was elevated, we were able to acquire end-systolic images on the T-wave and have a diagnostic scan in a patient who was found to have a normal coronary CTA. In this case, we used weight-based intravenous lidocaine for suppression of PVCs, which the patient tolerated well. This slide is a representation of how much nitrates can impact the caliber of the vessels. On the left, you see the patient who was scanned without nitroglycerin. Then minutes later, this same patient, as an example, was given nitroglycerin, and you can see how many more of the branches you see and how much larger they are. You can imagine how much impact this has on your ability to assess coronary stenoses of small vessels. It also can have an impact on FFRCT analysis. Here's an example of FFRCT in a patient that had no nitroglycerin initially, and there was concern about a problem with the scan. The scan was repeated with 0.8 milligrams of sublingual nitroglycerin. You can see more branches, larger caliber vessels, and you can also see that there's a difference in the FFR computations. Here's another case of a patient that underwent FFRCT analysis with no nitroglycerin compared to nitroglycerin. In a year previous, they received no nitroglycerin with small caliber vessels, and you can see the FFR values. On the following scan, a different year, they received nitrates, and you can see more branches and larger caliber vessels. And in this case, you can see how much of a difference it had on the FFR computations. There are two methods of contrast injection for coronary CTA. One is test bolus, and the other is bolus tracking. Let's go over the pros of each of those methods. With a test bolus, one of the advantages, we can actually get a sense of how much enhancement the patient is going to predictably have on their main scan. In other words, the degree of enhancement on the test bolus predicts the degree of enhancement on the main scan. It also allows us to have an opportunity to see how high the pressure went on the power injector by injecting a test bolus. If the pressure goes high on the test injection, then there is a high likelihood that during the main scan injection with a larger volume of contrast, that the injector will pressure limit and slow down the contrast infusion, which can be very detrimental. It can result in contamination of right heart contrast or simply inadequate coronary opacification. In addition, test bolus offers a potentially lower risk of major IV infiltration. In case the IV is tenuous and you inject only 15 cc's of contrast rather than 60 to 80, you have a minor infiltration versus an entire contrast bolus where you could have a more major one. We also get a chance to see how well the patient tolerates the contrast on the initial test run. It lets us see if they hold their breath appropriately, if they hold still, and if they have any anxiety or concerns that need to be addressed before the scan. This test bolus method also lets us have very precise timing to coordinate the breath hold for the scan. Sometimes we observe patients that can hold their breath for a long time, and it helps lower their heart rate due to vagal influence, and we can take advantage of that. Sometimes we find patients that can only hold their breath briefly, and we would time telling them to hold their breath closer to when the scan starts. Bolus tracking is the other method of image acquisition. The advantage of bolus tracking is that it can be easier and you can use less contrast. So you avoid the 10 to 15 cc's of contrast that you may have used for your test injection. It's important, regardless of which technique you use, that you are able to achieve the high flow rate needed for coronary CTA for the patient. We generally will inject patients anywhere in the 4 to 8 milliliter per second range, sometimes as high as 9 if the patient is very large. But we need to use warm contrast in order to achieve these high flow rates. When using contrast, we need to decide how much volume to inject and what rate to inject at. We decide this based on our scanner and based on the patient's body habitus. These are the main factors that influence what we choose. So we typically, on our scanner, use an injection time of 13 seconds for coronary CTA. Our variable depends on the patient's size, and that's flow rate. So a small patient may receive 4 cc's per second in most of our patients for a total of 13 seconds, and a large patient may receive 8 cc's per second for a duration of 13 seconds. The variable will be the contrast volume. It's important to know that this can vary depending on your scanner, depending on if you do a single beat scan or if you do a multi-beat scan. Contrast may be delivered for a longer time on a multi-beat scan compared to a single beat scan. So you need to know your scanner and how long your average coronary injection time will be. There are some patients that we actually use less contrast injection time, and the test bolus can be very helpful to letting us know when that's necessary. For example, a patient that has a very high cardiac output and rapidly transitions their contrast into the aorta and coronary arteries does not need contrast going after the scan is completed. In knowing that, we can actually subtract contrast, knowing that our test bolus enhances early, and scan the patient earlier than a typical patient. Here's an example of an optimally timed scan on a patient with contrast in the coronaries and aorta, but not much in the right heart. And this was a patient that was injected at a very high flow rate of 8 milliliters per second due to their body habitus. And we have good contrast to noise on these images. So to recap, the reasons we may have excessive right heart contrast or poor contrast timing could be because too much contrast was used, or it could be because your pressure injector hit its limit and the injection rate was slowed down. In either case, the images run the risk of being non-diagnostic, so it's very important for you to optimize your contrast flow rates and injection time. The last piece we're going to talk about is image reconstruction and its impact on image quality. It's important that we ensure appropriate ECG tracking of QRS complexes when we do reconstructions so that we time the reconstructions appropriately and have motion-free images. We want to reconstruct the adequate phase of the cardiac cycle that will provide motion-free images. We also want to avoid vendor smoothing algorithms for those scanners that will require the heart to be reconstructed over multiple beats. We will show examples of this. We want to reconcile artifacts when present, and if we can't reconcile the artifact and the scan appears non-diagnostic, the technologist should review this image with the CT reader and consider rescanning when appropriate. We also have pre-established reconstructions and kernels and iterative reconstruction strains that we can use depending on patient conditions. So for example, if a patient has dense coronary calcifications or stents, not only did you want to scan them with higher tube output settings, but you also want to reconstruct them with sharper kernel, higher resolution settings. You also may need to sample more phases in your reconstructions to provide to the reader, particularly when there's calcium, because calcium plus motion can be problematic, and having a larger sample size to sort through can help you reconcile the artifacts. So again, to review the artifacts worth considering while you're reconstructing, you have to look for motion, effect on the coronary arteries, misregistrations, noise, calcium blooming, and interpolation. How do we cope with these artifacts? Here's an example of scans with artifacts using different scan modes. In case 1, we have excessive motion of the aortic annulus. This can occur on any vendor platform, any scan modality, whether it's axial or spiral acquisition, single or multi-beat. Sometimes, depending on the method with which you scan the patient, you can reconstruct the image and get a motion-free picture as you see below. On the next scan, next case, this is a dramatic misalignment artifact on the patient's aortic annulus. This can occur on an axial or spiral multi-beat acquisition. This would not occur on a single beat acquisition volumetric scanner. Here what's happening is the patient is moving in between the heartbeats such that the annulus does not align appropriately. Sometimes though, your reconstruction method can reconcile this if you're fortunate and the motion occurred during a different part of the patient's heart cycle, the patient motion. And in this case, the patient had a nice reconstruction during systole, even though it was a very poor image on the diastolic image above. Lastly, you can see interpolation artifact. This would only happen in spiral scan mode. The reason this occurs is because there's missing data as the patient's moving through the gantry. They are moving too quickly for the rate. There's not enough data to register an image and it interpolates. However, if we're fortunate and we can fill in the data gaps when the heart is not moving during diastole, we can insert syncs and now you can see a diagnostic image. All of these are examples of cases that could be salvaged by alternative phase reconstructions or ECG editing. Here's an example of the importance of recognizing ECG counting errors. In this case, the patient not only had noise, but they had high amplitude P waves relative to the QRS complexes. And as you can see, the syncs, which are encoded by dots above the QRS and P waves, you can see how there's inappropriate sinks above some of the atrial contractions. This patient went on to get scanned, and when they were scanned, we had additional signal loss, and we inappropriately timed the radiation exposure. It was programmed for 250 to 750 milliseconds after the R wave, but because the R waves were inadequately detected, the radiation delivery was inappropriate. In this case, there was nothing we could do because ECG editing was not available, nor was there appropriate radiation exposure. Of course, the best solution to this problem is avoiding it to begin with. However, that's not always possible. In this case, the patient had repeated attempts at repositioning the leads, and there was always a noisy ECG signal. This is uncommon, but can happen. What we decided to do was to rescan the patient, this time in spiral acquisition mode. In spiral acquisition mode, we have the ability to ECG edit and remove unnecessary sinks. Predictably, this patient continued to have noise, but at least if our eye can detect what is the appropriate QRS complex, we can delete the incorrect sinks encircled in red and leave the appropriate sinks with the dots above the QRS complex as noted. The radiation exposure, you can see, we were trying to use pulsing, and when you do that in percentages, because the heart rate was counted incorrectly, you can see the fluctuation because the machine did not know how to appropriately trigger percentages on an erratic heart rate or perceived erratic heart rate. In the end, when this patient's reconstruction was performed with ECG editing, with the appropriate dots above the QRS sinks, the true sinks, we achieved a diagnostic scan. Here's another example of ECG noise counting errors and the problem you can encounter by simply letting the machine automatically reconstruct a recon that you have set up in your protocol. In this case, the patient had noise that went over the T wave and raised a sharp peaking T wave and caused it to count it as a sink. You can see that encircled in red. You can also see we were intending to scan this patient from 250 milliseconds to 350 milliseconds after the R wave. The algorithm sensed the arrhythmia and thought there was another beat occurring and determined it was appropriate to scan the patient at the same table position one more time. You can see that repeat scan demarcated by the red arrow there. And then the scan was completed with an appropriate sync on the final beat. So altogether, this would normally have been a 3-beat acquisition. We scanned the patient at the same table position twice because there was a perceived, albeit false, arrhythmia. Using the automatic machine-selected best systolic phase with the second acquisition of those two choices at the same table position, you can see how there's a marked misalignment artifact. In addition, you see a piece of the RCA on this volume rendered image that's missing. Instead, if we go and look at these QRS sinks and look at when radiation was delivered, although we cannot ECG edit, we see that radiation was at least delivered at a time that we can use if we use the alternative first of those two sinks on that second beat. By enabling the first sync instead of the second one, we do have radiation exposure of an appropriately timed QRS at the time we intended to deliver radiation at 250 milliseconds to 350 milliseconds after the R wave. We also know from previous discussion that typically the best image will be on the downstroke of the T wave. In this case, we had data at 325 milliseconds after the R wave, and we proceeded to make a recon. And now you can see the image without misalignment artifact, and the RCA is not obscured anymore on this volume rendered image. Here is an example of a case where a patient has motion artifact in combination with calcified plaque. On this scan, the patient's scan mode was a high-pitched spiral acquisition. Their heart rate was controlled and counted correctly with a steady heart rate in the 50s. When we scanned them in high-pitch mode and reconstructed the image, we reviewed the image, while the patient was on the table and recognized that there could potentially be a severe left main stenosis. The question was this a problem with motion artifact combined with calcium? If we leave it at this patient would be destined to have a cardiac catheterization with an unreconciled left main stenosis. Instead of letting the patient go, we decided to rescan the patient with a different acquisition technique. This time we scanned them with an axial scan acquisition mode, reconstructed the heart over 3 cardiac cycles. On this case, you can see how by having phase specificity and selecting the right phase, which we were unable to do in the high pitch helical acquisition mode, we were able to remove the motion artifact and have a motion-free image despite a dense calcification, and determine that there was only a mild left main stenosis, and therefore the patient, for this reason, did not need a cardiac catheterization. Here's an example of an artifact that's important to recognize during reconstruction, namely misalignment. On this image, which was acquired with an axial acquisition technique, the patient had respiratory motion and there's misalignment artifact right through a plaque in the mid aspect of the LAD. The LAD stenosis was indeterminate because of this misalignment artifact. This was recognized at the scanner prior to letting the patient go. The question is, do we let the patient go or do we rescan the patient? If we leave this unreconciled LAD stenosis, the patient may need cardiac catheterization. In addition, I want you to recognize the difference in reconstruction methods that are available on vendors' platforms. You can have a true axial reconstruction with no overlap, as seen on the image on the left, where it's very easy to see the artifact. There's no overlapping data. The images might look nicer on the right with some of the vendors' available smoothing algorithms where overlap is smoothed out, and you may not recognize the misalignment if that's done, and it could be mistaken as a stenosis due to blurring of plaque and blending of 2 different cardiac cycles. It's preferable to actually read the images that are closer to raw data, as you see there, so that you can recognize artifacts and not overcall or undercall plaques and stenoses. We went on to repeat this patient because it was concerning enough that we could not reconcile whether there was a true LAD stenosis. We did a repeat axial scan. We corrected the patient's respiratory motion. They were coached again on how to more appropriately hold their breath. We minimized motion, and we see no misalignment on this, and you can tell now that there's just a mild LAD stenosis and no cardiac catheterization was necessary for this patient. Both images here again show the true axial dataset reconstruction and the standard smoothed overlapping reconstruction, but you can see, compare and contrast these 2 data sets, both above and below. The true axial acquisition versus the smoothed overlapping acquisition is not unique to any vendor. This can be seen on a variety of platforms, and you need to make sure you're reconstructing in a method that lets you see this. The amount of overlap that can be seen may be roughly in the range of 1 centimeter. So if there's plaques or lesions falling within that 1 centimeter of overlap, you can have this problem. Here's an image of a patient with a dense calcific nodule in the coronary, and when you identify these, in addition to your standard reconstructions, it may be helpful to make some sharper kernel reconstruction, higher resolution images, so that we can have a more accurate depiction of the lumen. Here's an example of the importance of appropriate phase selection in reconstruction. All of the vendors typically provide a best phase algorithm to try and select the most motion-free image. In this case, it may have not worked appropriately, and been timed incorrectly on the right coronary artery. The right coronary artery tends to move more than any vessels and may be one of the ones you want to look at first in making your decision if you have an appropriate reconstruction avoiding motion. What we do know is if we have radiation data that expose the patient at an appropriate time in the cycle, and we know from our previous ECG discussion when those timings may occur, we can make our own reconstruction if the algorithm did not select appropriately. Reflecting back on what we discussed earlier, on a high heart rate patient, we would typically do a reconstruction on the end of the T wave. On a low heart rate patient, we would do the reconstruction pre-P wave. And in so doing, we may be able to make our own reconstruction with an image that is motion-free. The other opportunity you have to provide the reader with motion-free images is to reconstruct a multi-phase data set. By doing that, there will be a larger data set of reconstruction to review on the workstation, but it allows the reader to flip through the phases and determine on their own which phase is best. It's important to not only do this sometimes in percentages, but if you are able to do so, to do it in milliseconds, particularly in patients with arrhythmias. As you can imagine, if a patient has a variable heart rate and you can reconstruct, for example, at 45% of the RR interval, in a low heart rate patient, that could be in diastole, whereas in a high heart rate patient, that could be in systole. On the other hand, if you do that reconstruction in milliseconds after the R wave, you will generally hit, regardless of variations in cycle length, the appropriate timing you may want, for example, on the end of a T wave. I hope this opportunity today to learn how to optimize coronary CTA was very helpful. I appreciate the opportunity to participate in this educational activity. If you have any additional questions, please connect to us with the email link below.